Dr. Robert Clay, who is in transition, as they say, and will soon be the Vice President for Health and Nutrition at Save the Children. But this is after a 30-year career at USAID, where a number of us have met him in some of his assignments as the officer in charge of health, population, and nutrition in Zambia, and then in India, and then head of the HIV/AIDS Bureau, and finally, at the end of his career, as Deputy Assistant Administrator for Global Health. So he really does know whereof he speaks. His accomplishments have been recognized by Distinguished Service Awards from both USAID and PEPFAR, and maybe it's an in-joke, but it's a trick to get an award from both of those. So we're very grateful that he was able to come up and speak today about USAID, where it's been, and I hope a little bit about where it may be going in global health. Robert?
Thank you very much. I had a little preview because I had a nice lunch. Sorry for those of you who haven't had your lunch, with some students here, and we were having a conversation about a little bit about global health, but also how students can engage themselves in global health in the future. So it's fun to be back in Boston. I come here from time to time, and thank you for the invitation. I'm talking about 50 years of global health, and a lot of this will be focused on USAID. And I apologize for that. That's where I've served now for 30 years. But I'll be bringing in as much as I can from the other U.S. agencies, CDC, HHS, DOD, and so forth. So I'll try to bring that flavor in, and then if you have questions at the end, we can obviously explore that a little further. As I said, 30 years at USAID. It's not 50, but I have been trained by many of those who were there at the beginning. So my mentors go back, so I feel like I do have some understanding of the early days at the agency, which I'll try to pass on. I have 19 slides, and I will try to be quick. It's going to be a teaser. It's all written out in much more detail in this book, which I understand is on the site.
It's linked to the Global Health Blast, so any of you who are on our mailing list, if you go in, it'll be linked, and if any of you have any trouble finding it, see any of us in the department will see that you get the link.
Let's go. So press here? Yeah. Okay. So just by explanation, this the report that I mentioned here, this one, really came out of a realization that many of the USAID staff have been with us for less than 6 years. And their view of global health was really one that's been shaped in the last decade, but not the 5 decades that really USAID has been engaged. And so we wanted to present the history so that they would also know what legacy they're going to be carrying on in the future. And it's actually been a big success. I knew when I first started this project that it was going to be good because I brought together about 20 of our health officers, and we were supposed to design and figure out all the logistics and so forth. And we spent 2 hours just talking the stories, telling about what we were doing and what our experiences have been. So there's a real need, I think, for storytelling, and that's really the way that we're approaching this, is that we want this to be a living document for people to add on their experiences. It is set up electronically so that you can link onto other documents, because you can't bring all of this into one pamphlet like this or book. So we have links in which you can explore other things. One of the key themes that I hope you'll take away with you is that we do have repeating issues throughout our 50 years. And I think that's one of the things that many of us old-timers inspired us again for this book, is to see that many of the same fundamental issues which we tried to deal with, are still there and people are still struggling. And we're feeling that we need to share our experience so that we don't, again, have to redo things. We decided in this presentation in the book to establish it by decades. And areas that we talk about, the technical areas, obviously cut across those decades. So it's not a complete division, but we felt that there were some very important themes that we could then identify around the 60s, 70s, 80s, and so forth. And just to start off, I don't know how many of you know that USAID was actually founded in 1961 by President Kennedy. This was after a lot of effort that had gone in looking at global health over about the last 100 years. It really started, at least from our research, looking at cholera and a major conference that was held in Paris in 1852, focusing on the sanitary conditions. And that theme of looking at sanitary conditions and cholera also continued in the early 1900s with work in the Latin America region with the International Sanitary Bureau, which eventually became PAHO, the Pan American Health Organization, part of WHO. So the first entree into global health really started with the sanitation and viral disease work. There was also a big focus in Latin America for the US government at the time, and many different agencies were focusing on how we can help our fellow countrymen, our countries that are in that region. We also have the assistance in the early part of the 1900s with the Rockefeller and the Ford Foundations that were established, and particularly the Rockefeller Foundation establishing schools of public health in various different countries. President Truman established the 4-point program, which if you ever come to USAID, our conference room is actually named 4 Points. It's sort of the basis of how our assistance was defined at that point. And then, as I said, in 1961, the agency was established. The business model, as you see here on the slide, had a very strong field perspective, technically support from headquarters, but the field was really in charge of, in many ways, very similar to many other developing agencies today, of a decentralized model, where there's still some tensions in that model because we need to make sure that we report on results. So I can talk a little bit about that in terms of the most recent organizations that have been changing. We are a development agency, not just a health agency, so we had a mixture of different disciplines that were part of our organization. And very importantly, we had bipartisan support from the beginning. And I think particularly in global health, this has been one of the real saviors of our field, is that no matter what administration is in the White House or controlling in Congress, we've had strong support for global health on both sides of the aisle. Now, I'm going to be going through then each of the decades, and I start really with, as you see on the left, are some statistics, and in the book we continue that decade by decade, so you can see some of the progress that have been made in terms of fertility and under 5 mortality rates and life expectancy. But also, an important theme that emerged from the work is that global health doesn't really reside as a sort of an isolated program. It's influenced tremendously by what's happening in society around it. And in the 1960s, we termed that decade the decade of development. There was a lot of optimism about what could be happening. In fact, President Kennedy, when he established USAID, he felt in 20 years we would be out of business because in 20 years we would basically finish the job. There was this idea at the time in the 60s that industrialization would really lead to modernization. And I served in India, and that debate was very, very strong in India between Mahatma Gandhi, who was very much of a local community-based individual, and then Prime Minister Nehru, who was very much into the industrial model. And so that tension have been playing out. But in the 60s, people were fascinated with this idea that, that we could use with industry, that you could have what they called sort of a takeoff point. That if AID got a country, helped assist the country to a certain level of industrialization, then that country would just kick off and be able to springboard forward. Of course, there was a lot of countries that were gaining independence at the time, many in Africa, so the political agenda was quite important. There was the height of the Cold War, so a lot of the alliances were formed with that backdrop. And there was, of course, technology was really seen as key as solving problems, and probably most represented by the Green Revolution, which started and was able to make some remarkable changes in countries around the world. On the health side, the 60s was a time when we saw a lot of success in terms of smallpox eradication. Measles were added in terms of routine services through our immunization program. In 1965, USAID started the Family Planning Program as our really first major initiative in global health, with a real focus on the challenges of demography. And Paul Ehrlich, I think many of you know, wrote a book in 1968, sort of laying out the disaster of a growing planet and the lack of resources with more people. And I think that galvanized the whole society to be supportive of family planning for the first time. Up to that point, it had been really an issue that many vocal and very forward-leaning women have been proposing and fighting for, but hadn't really seized much of the imagination. And I think with the population bomb, name of the book of Paul Ehrlich, it really seized on a sort of a broader mass appeal. We also continued to do work in nutrition during this period, obviously along with some of the Green Revolution work. And we had, because of this sort of focus on industrialization, there's a lot of emphasis on infrastructure. And so we were involved at USAID with building hospitals, the rest of, in other sectors, roads and dams, many of the kinds of things that you often see currently supported by the Chinese or the Japanese in many other countries. And it's a very visible project or representation of development. And I think donors tend to do that at the beginning stages of their work, because they have to really justify their budgets, and they have to demonstrate results. So I think, as we've seen with other donors, this phase of going through and building infrastructure is something that happens early on. So then we get to the 1970s, and of course this was, the Vietnam War had been raging for a while. There's a lot of the optimism have evaporated, and there was a feeling that these large-scale projects were turning into what was termed white elephants. They weren't having an impact. That we were building things, we were getting credit, but people's conditions weren't changing. And so there emerged broadly this whole idea of basic needs in terms of what people needed to survive. And this became part of the legislation in the New Direction legislation in the early 1970s, where it really focused much more on growth with equity as opposed to just growth by itself. And in some ways, this change to basic needs has been guiding the agency ever since. Our focus at community level, working at the basic interface between with clients and with providers, and looking at their needs in both in the social sector of health, education, and has been a defining factor in a lot of our work that we've done. We also saw a major shift from direct implementing programs to looking more at strategy guidance. And in some ways, this is parallels what happened with the rest of the U.S. government. Many have said that it's really Robert McNamara's influence at the Pentagon of moving away from direct services to contracting out, to having other people do a lot of the implementation. Before the Vietnam War, USAID had a staff, I think somewhere around 12 to 15,000 people. We had engineers, we had folks that were actually going out and doing the work themselves. They were direct government employees. And after this period, we started to engage in more local groups, NGOs. We also had quite a number of relationships with universities. Johns Hopkins University had the Naringwal project. They ran for us in India. UCLA did the Dantha project in Ghana, where they were running major research programs and looking at how we can best deliver primary health care at the community level. But it wasn't USAID doing this, we were contracting out with other groups. There was a broad shift, I think, in terms of global health, or at that time it was called international health, from looking at very specific diseases such as smallpox or measles, to trying to build up the infrastructure. And this all culminated in a big conference in Alma-Ati in 1978 called Health for All by the year 2000. It was a declaration looking at primary health care, getting the services down to the people, building up that infrastructure, and the World Health Organization really took the lead on developing that. In the 70s, along with this shift for basic needs, Congress decided that it wanted to provide funding for development not by a broad account, but by looking at 9 functional accounts. So each area would be having a separate account. So in a sense, it started this idea of earmarking funds for particular areas. And ever since, our budget is very earmarked along different accounts, and even it gets very, very specific in other areas. But that started in the 70s with the shift of moving, Congress wanting to see the agency move into this new directions legislation. We saw the continuation of family planning as we have, as we mentioned early in the 60s, establishing it in 65. But I would say the 70s and 80s were really the golden era of family planning. Largely because of the controversy around family planning, it was mainly managed out of the Washington area. And we had about 50% of the resources based in Washington, with the other out in the field. The rest of the program was much more decentralized, but with the family planning program, that was not so. We had a lot of procurement, commodity procurement that was put into place. And in many ways, the feeling was that there was an unmet demand for family planning in countries, and what was needed was the supply. And so it was very supply driven. This was the time when oral rehydration therapy, one of the major interventions and innovative therapies that came, was developed. It was during the Bangladesh, or the East Pakistan and India wars that then developed into Bangladesh. And that was tried out in refugee camps in the 1970s, and then was gaining momentum, and we'll see in the next decade how it really is expanded more rapidly around the world. Community health workers, community-based distributors, all of this at a community level was a key part. And then the beginning of this partnership as we're doing more with others, not just doing it with ourselves. Now, the 1980s, again, we see some bit of a backlash because of several things. One, there was a lot of loans that were taken out by these new countries that developed, and they weren't paying them back, so there was a lot of fear of loan defaults. We also had this shift from just managing projects ourselves to going to more programs. And we also saw a much greater focus on sort of the free market principles and looking at the private sector and how they could actually play a role in the development arena. We also had new projects that we developed in terms of looking at our collaboration with NGOs and PBOs. A major child survival program was developed with our NGO partners during this period. And I guess in terms of health, the major change was from a broad, comprehensive approach that was represented by primary health care to much more of a selective approach, driven by, in some ways, a broader event around development, which was the economic recession that was happening, and the need to justify our budget in order to get resources to fund global health. And one way to do that is to link resources to achievements. And by saying that, if Congress gave their money, we would build a system which may take 10 or 15 years to materialize, versus if you give me money, I will save X number of lives, children's lives. That was much more palatable in that world. And Jim Grant, the former director of UNICEF, was the master of using this selective primary health care to really expand programs in global health during this time. At USAID, we focused a lot on ORT, which was kind of the intervention that we selected as a major expansion, so it became part of our hallmark on child survival revolution. We continued our work with water and sanitation. This was the hallmark of training of health professionals overseas. And if you ask any AID staff what was the real contribution of the agency, many of them would say the number one contribution has been training of our host country counterparts in our program. We sent thousands of people to schools to get degrees, advanced degrees, and these individuals are now running their health programs overseas. And I know when I was living and working in countries, my counterparts would often reminisce on their times when they were in the US and what they learned. And it was very, very, I think, helpful, both for the quality of the programs and then the relationships that we had with them over time. And I think in the 90s, because of budget constraints, this part of our program was collapsed. But I think it's I think it really is an area that we should continue to promote. The demographic health surveys, building on the World Fertility Survey, was really expanded in the 1980s and 90s, and has been a gold standard for surveillance and the work that we've done. And also during the 80s, we had an increased focus on behavior change communication, particularly looking at the child survival interventions and how we use multiple channels of communications to really get to the core issue of changing behavior, and not just awareness and knowledge, but real behavioral change. I should say that 80s, 90s, and on, it's a little harder for me to talk about because those were the decades that I lived. So I could go on forever about these. So I'm going to, because of time, I'm going to have to be a little concise here. But maybe if you have questions, I'll be happy to share some of my perspective more in detail on these decades. The 90s, we had this backlash on structural adjustment. A lot of countries said that many of the social indicators that we were tracking in terms of in the countries' populations were being affected by the cutbacks and the changes. There was a big focus in terms of the U.S. government reinventing itself, trying, because of the economic crisis, to try to do things more efficiently. And for many in the development world, that meant reduction of staff, not hiring. And we were just talking just a while ago, Rich and I, how there is a sort of a 10-year gap in terms of our professionals that were where we didn't hire, and so we hired later. But there's this gap period within the professionalism within the government because of this. The HIV/AIDS epidemic obviously became very visible during this period and became a large focus. For early stage prevention, there wasn't really the treatment at this stage, or if it was very expensive. So those of us in the field, we spent a lot of time trying to see how we could promote prevention efforts. And in some cases, like Uganda, there was We've had some good successes early on, but the mortality continued. And then we had a renewed increase focus on tuberculosis, obviously linked with the HIV/AIDS epidemic. Also, this period saw an increased focus on decentralization of health systems, and really some of the health systems reforms, the early ones that looked at user fees, looked at ways in which we can make systems more sustainable. I wouldn't say it was mainstream at this point, but there were a few donors, USAID, the World Bank, that were pushing on this area to try to address the issues that were coming up with the more selective programs, which is how do you sustain them over the long term and how do you build that infrastructure for them. So we had a renewed the USAID TV program, the Malaria program, renewed leadership in that, and then finally we had polio eradication in the Western Hemisphere. And the optimism of the time was that we would be able to eradicate polio by 2000. That didn't happen, and we're still working, but the levels are at the lowest that they've ever been. So I think people are very optimistic that we'll be able to do that shortly. Now, moving on to the decade of the 2000s, in many ways, the MDGs, the Millennial Development Goals that we're all thinking about now in 2015, they really were quite a unique commitment by the world to focus on these particular areas. And I was engaged at the global level, and it was very, it wasn't a large effort, and it didn't have a lot of consensus. It was a few people, a few leaders who really drove the process, and I think most of the people kind of got behind it at the time, but then in many ways forgot about it. And I think the early part of the decade, they were there, but I don't think they became very influential. As opposed to later in the decade, and certainly in the 2010 decade, they've become really a defining prism or a way in which we look at success and results that we're attaining in development. Of course, 9/11 really changed the whole tone on the international development. And for so many years up to that point, in development, we were trying to show our relevance to foreign policy, to the rest of the agenda of the U.S. government. And with 9/11, development became part of the 3 Ds, defense, diplomacy, and development. And it was a realization that you couldn't just go in with a defense approach or just a diplomacy approach, that you had to really bring in development for the longer term effort for these countries. And that really has elevated development work throughout the U.S. government. And I think it was really the hallmark of that was when Secretary Gates was testifying on the Hill, and he said that basically he was arguing for more money for development and as opposed to defense, saying that that's where the money was needed. And there's a quote in the book, I think it says something like, it's cheaper to have development than it is to send a development person than it is to send a soldier. So that's really it's a remarkable change in terms of the visibility that development received at that point. Throughout this period, the recipient countries were asked to play a bigger role. Many of the people have been trained, and as we've learned more recently, many of those economies have actually grown, so that they now have the resources to be able to put against global health, where before we were or donors had to fill the gap. We had huge mobilization at the global level. The Global Fund to fight AIDS, TB, and malaria. I was in Zambia thinking the world had forgotten about people living with AIDS in 1998, and we had no idea that we would see this mobilization. And it's an interesting story of how that actually happened. We don't have the time, but if you're interested, I can share that later. And then, as I said, we had large foundations and many more corporates that are engaging in global health. So we had a much more aggressive AIDS response. The PEPFAR was established in 2003. expanded our programs in terms of looking at orphans as in many ways, orphans is a window to some of the issues that HIV/AIDS brings to society, and many people came to supporting HIV/AIDS programs through the orphans work that they were doing. Successful partnerships to drive down neglected tropical diseases during this period, and then a strong network that we've had with many of the different partners. So this decade, we call it USAID Forward, where there's a program at USAID where we're trying to make the agency, the bureaucracy, more responsive to the issues today. This was largely driven by the global recession, which really accelerated the need to share responsibilities. And as I said, as the West was going into recession, many of these countries were actually growing, particularly some countries in Africa. And so it just became natural that we started a conversation about a partnership and the role that they could be playing more in the programs. And then science and technology has, again, continued to be important. And in some ways, our investment in the early 2000s in science and technology was starting to show its fruit. And we're starting to get some new technologies that we're able then to roll out, and I think that enabled more support for this area. And then a focus through the Global Health Initiative on more cost effectiveness and integration of programs. Again, in many ways, getting back to the Health for All by the year 2000 primary health care model, but differently, in a sense that we're not trying to do everything under primary health care that we thought in the 1970s, where we overloaded the community health worker, but try to be much more selective about the interventions, but have them integrated, and integration where it made sense for the programs. There has been a call to action, renewing our focus on preventing child and maternal deaths, a big conference in Washington. Focus on data collection, again, to justify and show how our programs are achieving results. Technology, and then on graduation and sustainability, to make sure our programs are going to last in the long run. Everyone loves to see graphs on funding, and this, I think, is a very telling graph. When you look back to 1967 and you see the amount of resources versus 2012, a lot of the change you see happened in 2002 to 2012. Most of that was through the PEPFAR program. So we also saw increases in other programs, not as large as that. But in many ways, I would say the PEPFAR program changed our dialogue on resources from millions of dollars to billions of dollars. And when President Bush committed himself to, I think it was 15 billion, it was shocked many people. But since then, everyone who comes up with a new program is talking billions of resources for our effort. Now, don't let me leave you with thinking that this is going on forever, because actually, if you look at 2010, going across, it's more or less flat line. We have been very fortunate in a very tight fiscal year to see our resources hold. Many programs have actually had a reduction. And I think with continued support, the vision of ending preventable child and maternal deaths, and then the continued the outbreaks that we see with Ebola, it generates resources and interest in global health, and that continues to provide us with support, bipartisan support. So what's next? Really, as I said, these two bold visions, which were unimaginable when I joined the agency, trying to end preventable child and maternal deaths within 15 years, and then creating an AIDS-free generation. It's really driving the programs and I think inspiring a new generation of working in global health. Responding to this economic transition of health and encouraging universal health care coverage as countries have more resources on their own. The changing demographics and shifts in the global burden of disease, the non-communicable diseases issues. The evolution of the new donor environment. I haven't spoken a lot about that, but with the foundations coming in, with many more NGOs, with diverse funding sources, it's a very different landscape, very cluttered, very complex, And some of you who work in development and having to get funds probably know this very well, probably better than I do. But it's quite different with, it's good as long as we don't cannibalize each other and that we grow the pie. And then continue to focus on innovation and technology as we progress. So the one thing I haven't really said much about, which is really another driving theme right now, is this issue of poverty. And as a focus of USAID, our overall focus is to end poverty as we know it. This is a pledge also with the World Bank and others. And global health plays a key role in that. But I think if we're continue, even with the current progress that we've seen, if we continue that, we'll be seeing rapid changes in our world, and changes of relationships and changes of disease patterns. But we feel that with added attention and with new technologies and a little push, that we can actually bend that curve more steeply, and we can see more rapid work. And of course, all of you, particularly the young students here, are going to be the ones who deliver on that. So we hope that this inspires you and that you're able to fulfill the dreams that we all went into this work for. Thank you very much.
Thank you. Robert kept exactly to his pledge on time, so we have about 8 or 10 minutes for questions. So I would encourage him. Robert, I won't bias things by calling on people. I'll let you select your question.
Thanks. I was nostalgic about your 1960s slide that talked about eradication of smallpox, vaccination of all children with